This is inverted 3D vitrectomy, fibrovascular tissue and ILM PO for severe diabetic retinopathy with retinal detachment. Retina Pics and angio display preretinal fibrosis and tractional retinal detachment. OCT reveals a large tractional component as well as surface macular involvement. The patient is phakic. A 23 gauge Pars Plana Vitrectomy is set up and a wide fibrovascular band is noticed, crossing the macula from the topography of the superior temporal arcade reaching down below the inferior one. Cautery is used. Retina sort of shrinks when cautery is used. Sometimes it helps in detaching fibrous tissue from surface retina. Band is now approached, aiming at detaching it, relieving the traction crossing the macula. Notice sclerosed vessels all over the macula. The band was cut precisely, deep enough not to reach retina, and adhered hyaloid was then removed accordingly. A 25 gauge ILM forceps is used here as to lift up the membrane to grab the tissue and dislodge it from the retina adherences. Epiretinal tissue is stored away as a great cleavage plane is reached, allowing it to be separated beautifully as a layer. Epiretinal tissue is removed gently from retina surface everywhere. The direction may be switched from one side to the other and vice versa, and finding the safe point to pull the membrane is of utmost importance. A very powerful adjunct is perfluorocarbon PFC liquid because it has a great surface tension downwards and may also be used as a tool to hold the retina firmly, allowing membranectomy and manipulations if and when necessary. In the present case, PFC could well keep the retina stable and also served as to halt some preretinal hemorrhage due to its characteristics. After it is removed, some still active vessels could well leak, but they are targeted with back flush cannula and oftentimes the cautery. In nerve fluid exchange, AFX is the next step of the procedure now. And why it is that? To follow on with the ILM internal limiting membrane PO to further relieve any traction secondary to fibrous proliferation that could well be interwoven in the internal limiting basement membrane of Miller cells. For that purpose, brilliant blue is poured on the macular surface after this complete AFX and should not stay long, but only long enough as to stain the ILM, so saline solution is allowed back into the eye within a minute or so. Staining was very good, and the ILM forceps 25 gauge is now back into action after the bluish membrane, lifting it gently and slowly as not to cause any secondary tear on the way. A sclerosed vessel can now be better visualized due to the contrast created between the membrane and the nude area. Other areas are reached around the optic nerve and elsewhere, aiming at relieving as much ILM as possible. Finally, macular ILM PO is completed as it looks pretty free now. Backflush cannula is used to remove remaining preretinal blood spots around. Perfluorocarbon is injected back again, now to stabilize retina further, allow for endolaser and halt remaining hemorrhages. Helped by the intraocular pressure, of course, the IOP cannot be set high in this way avoiding occlusions. And the laser is now performed in a pan-photocoagulation fashion. An inferior tractional retinal detachment is now settled down even with PFC over it. So besides laser around it, a central retinotomy at its core was created to sort of relieve retina and make it more mobile. The retina sits on the choroid and no PFC is allowed in. The arc of contact from the PFC meniscus makes it very safe not to go under retina, which is now pretty well relieved at that area. Time now for a direct exchange of perfluorocarbon liquid for silicone oil. Notice the lens is kept clear during the whole procedure. A complete fill is reached and all PFC removed. Macula looks pretty flat with no tractions and free of epiretinal tissue or fibrosis. A stitch is put crossing the conch just in case. I appreciate your attention.